Good afternoon and welcome. Thank you for joining us today for our training and introduction to creating a trauma-informed culture in the post-acute and long-term care facility, Part 4, Grounding as an Essential Strategy to Calm an Activated Nervous System, hosted by the Center of Excellence for Behavioral Health and Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. Now, I am happy to introduce our presenter for today, Ms. Paige Hector. Paige is a consultant, nationally recognized speaker, and author with over 25 years of experience in post-acute and long-term care settings. She specializes in diverse topics for the interdisciplinary team, person-centered trauma-informed care, nonviolent communication, sustainable process improvement, and advanced care planning. Paige writes extensively on topics related to nursing homes, including multiple chapters of Managing the Long-Term Care Facility, second edition, due for publication in 2023. Paige is currently the associate editor and a regular columnist for Caring for the Ages, the publication for AMDA, the Society for Post-Acute and Long-Term Care Medicine. In 2018, she was named the Gerontologist of the Year for the Arizona Geriatrics Society. And now I'll turn it over to Paige to begin the presentation. Thank you, Paige.
All right, thanks, Nikki, and hello, everyone. So nice to have us all back together talking about a topic I am absolutely loving. So this one, we're going to be focusing on grounding as an essential strategy to calm an activated nervous system. The objectives for our time together today, we'll talk about reactions, which I define as the things that people say and do associated with an activated nervous system. We're going to obviously talk about grounding. That's going to be a huge part of what we're doing today. And then trauma-informed touch. And I will always, whenever I talk about trauma-informed care, I'm always going to find ways to bring it back to staff because, again, my perspective is that until we create these environments that are trauma-informed for staff, we can't do that for our residents and patients. So as we go through this, I invite you to put on your QAPI hats. Think about what might I do with this information? What piques your interest? What might you think of trying in your work setting to see what you might do with the content we learned together today? So just to revisit, this is a recap of the topics we covered in parts 1 to 3 of this series. So we're on part 4. I won't go through all of this, but if I'm saying things in this session that you're a little bit more curious about, there's a good chance I've covered it in another session more in depth. So we've tried to build these to be a foundation, 1 builds on 2, builds on 3, that sort of thing. Let's start off with this. You'll notice I do a little bit different in terms of the languaging. I don't just say trauma-informed care. I do like person-centered trauma-informed care, because to me, everything that we're talking about, everything that we do in nursing homes, and I also will include our colleagues and friends in assisted living, is that it's all around the individual. It's all centered around the human being. So person-centered trauma-informed care recognizes the pervasive nature of trauma, integrating principles and practices. And today we're going to really focus on the last few words of that definition: healing and recovery. So before we jump into the actual grounding strategies, I want to look more in depth at what happens with an activated nervous system, because this is really where the idea of noticing when a person is triggered, noticing when to bring those trauma-informed care principles, when we need to bring those to life. So let's start here with the nervous system response. I've indicated here a really important part of the nervous system is this little tiny part, like the size of an almond, the amygdala. This is where our memories are stored. It's super tiny. It filters and sorts everything that you experience all throughout your day. That little part of your brain is working super duper hard. And what it's trying to do is identify, is there anything in your current environment that replicates or simulates or is similar to anything that happened to you at any point in your life up to this time. It's particularly looking for anything that's considered stressful, traumatic, difficult, or dangerous situations from the past. That little tiny part of your brain and what it's doing approximately 12 to 100 times per second. Isn't that amazing? Per second, it's essentially asking yourself, am I safe and do I matter? That's the ongoing mantra of that little part of your brain. Am I safe? Do I matter? Am I safe? Do I matter? And it's scanning your environment because its sole purpose is your safety and your well-being. When it detects that there's something that you might need to pay attention to, that there's some kind of danger, it's going to trigger an alarm. We might call that being triggered. I also prefer the language of reactive, emotionally stimulated. So any of those work, whatever term you like. Triggers is what I think is most well known. So these are reminders of dangerous or frightening things and or people that happened in the past. And you'll notice there the asterisk in the past can mean any time, yesterday or many, many years ago. And the person re-experiences that event all over again. I want to point out that does not necessarily mean that they're re-traumatized. The way that I understand re-traumatization is that our ability to function in the present moment is even more diminished. So if I'm triggered and re-traumatized, it means my ability to function is actually lessened. So a lot of times we can get triggered by something, but it doesn't necessarily impact us as re-traumatization. So to me, those are very different. They're related, but different concepts. So triggers come without warning can be literally anything. You know, I actually was creating slides of potential triggers, and there's some that are very, that are potential, whether it be sights, smells, particular visions, things that happen that we see, but anything, absolutely anything can be a trigger. Sometimes it's very difficult for staff because we can be working with a resident and all of a sudden they're doing something or they associate something that we're doing as being dangerous, even when our intention is anything but. The person may not even associate a trigger or even know it's happening. So a lot of times our brain can do things that we're not even aware. We've not made the connection that this trigger, this sight, this smell, this sound, this social situation, this thing in the current environment is directly related to something that happened to me 2 years ago, 80 years ago, whatever time frame. What might be stimulated then as a reaction, and I do prefer that as the term rather than behaviors, because in healthcare, we know what we say. When anyone in healthcare, if you say they're having a behavior, that has a whole set of judgments and labels associated with it. So I know in my work, I'm really trying to move away from that. That's becoming more trauma informed in the way that we think and the way that we interact with people. So these are things that people might do that absolutely can contribute to challenging care situations. So of course, this list can be very long. What I want to bring forward in terms of trauma-informed care, these are actually coping mechanisms that when the person experienced trauma or stress, they exhibited these reactions that at the time made perfect sense at the time that that experience was happening. In the present environment, they may no longer suit the circumstance, but they began as modes of survival. So for me, this idea really softens me when I'm around someone who's doing something that I don't particularly enjoy. If I can tell myself and associate that, oh, I wonder if it's possibly related to a traumatic or stressful experience from their past. That really does help me to have a different framework. So what we know about trauma is that it imprints the mind, the brain, and the body. This is an excerpt from Dr. Bessel van der Kolk's book, The Body Keeps the Score, that we have learned that trauma is not just an event that took place sometime in the past. It's an imprint, like your fingerprint, right? It's an imprint on our mind, brain, and body. And this imprint has ongoing consequences for how the human organism manages to survive in the present. So those imprints that happen to us throughout our lifetime, which are cumulative, they stay with us all the time, triggerable, literally at any moment. What it means is our body, that amygdala is gone, has set off the alarm, and it's saying, it can be interpreted as, I'm not safe, I cannot protect myself, I could even die, or I don't matter. I've added that last one because it's such an important part to our being human, is to know and trust that we matter as a human being. And when we don't trust or believe that we matter, our alarm system will go off, and that's when we see stimulated reactions to the environment. So here's some new content I want to introduce you all to. So let's talk for a moment about memories and what happens in the amygdala. The memories are not time-stamped, and that's super important for understanding trauma in the present moment. So the amygdala has no way of time-stamping, oh, this happened when I was 5 years old, I'm no longer in danger, because now I'm 55 years old and I'm no longer in that situation. So the amygdala does not timestamp the memories. It has no way of knowing that the memory has ended. So let me give you 2 examples. Getting attacked by a dog as a child, and then now this person is in your community and you have a lovely pet therapy animal that comes in, the sweetest, kindest, most yummiest little dog that comes in and sits on people and is just wonderful. For this particular person, what's happening physiologically is their heart rate's going up. They might exhibit fear, even though there's zero danger from this animal, because their amygdala has set off the alarm for them. The amygdala is sprung into action based on the memory that was imprinted in the brain as a child. Another example, a person who has been in an abusive relationship or relationships had very little choice in daily life. Now this person is a resident in your community and basically is told, okay, and we still do some of this, although I think it's less and less. The showers for this particular neighborhood or community are on these days, or in the morning or in the night. So this person, when they receive that as having no choice and not mattering, they shut down. In other words, they give in or they explode on you. So if I can help us understand that what happens in our lifetime, it can continue to be re-experienced throughout our life at any point in time. So I want to show you a visual analogy of what happens, the power of the memories that are stored in the amygdala. Loved this analogy. Sarah Payton is one of my favorite people in this world of trauma-informed care. In one of her books, she was talking about the associations that we form as vivid memories of emotionally significant seconds in our lifetime. And she called them a glacier. Isn't that just a phenomenal idea here? That this entire glacier of emotionally significant seconds, triggerable at any moment. So that glacier might lurch, and see how this is breaking off here, this chunk of ice. It's breaking off. It's like the glacier is lurching, and it comes as to staff as rage or unexpected storms of tears or out of nowhere feelings that just don't seem to make sense in the current situation. And that glacier, we know they can move very slowly. Things that a person is building up and they're just beginning to isolate more or decline care or become a little bit more agitated. So it can be sudden or it can be slow. The power of the amygdala in terms of trauma. I want to give you a little, I wrote a little bit of an excerpt here based on, I know, my experience of many years in post-acute and long-term care. And I want to give you an example of how this might show up for us. A woman moves into your community following hip replacement surgery. She was found in her home after being on the floor for 4 days. The mail carrier, as they often do, is the one that sounded the alarm. She was laying in a crumpled body position, a puddle of urine and feces and very strong odors. The phone was just out of her reach and ringing intermittently until it died. A pet is whimpering with fear and hunger. The pressure of the walker stuck beneath her body. The feel of the cold tile on her face and the horror that she could die and die alone. Other very intense emotions like shock and pain, terror, and confusion. So I've just painted an image of something that I believe probably happens quite frequently in our communities. Now she's moved into your nursing home. The amygdala did its job beautifully. So all those descriptors that I just read to you are actually stored in her brain, in the amygdala. The imprint is there. And remember, now she's in your community and she's really very safe. You're taking great care of her. Her hip is healing well. Everything is fine. However, her amygdala is still scanning. Remember what I said, 12 to 200 times per second. Am I safe? Do I matter? Am I safe? Do I matter? Looking for life-threatening, anything that could be dangerous to her. So she may not even be aware that her brain and her amygdala are doing that, but yet it's going to identify a similar sensation or perception if it triggers that there's something not right in her environment. So now you go in, whatever your role is, perhaps you're a nurse or a CNA or even a social worker, you're going in to do ADLs or a therapy eval or do a psychosocial assessment. You go in and she becomes distressed that something has triggered her in her environment. Maybe she declines care, she starts crying, she's yelling or argumentative. So it's just an example of how our past experiences imprint on our current environment. What might be happening in the nervous system, it shows up as many, many different things, but here's a few that you can look out for. The pupils that dilate, muscles tensing up, and you can see this in another person, right? You've maybe been with someone and you can just tell there's an energy shift and something happens. They become tense, their face changes, you can see the tension in the face, repetitive movements like twisting a tissue in their hand or fidgeting, bouncing up and down, movements, repetitive, changes in speech. Either it goes really fast, it goes way, way slow, or they completely lose coherence. Breathing changes. And this is where, when we get to grounding in just a few minutes, the breathing changes, that's going to be one of the biggest things that we're going to be looking for as we bring grounding practices on board. I want to just bring in a little of my work with nonviolent communication. So the feelings that happen in our bodies, agitation, horror, disgust, pleasure, joy, all of those things that happen are also associated with physical sensations. So just take a look at these lists here, and you can organize them differently if these are not set in stone by any means. The more that we can become attuned to what is happening in our bodies and using that language and helping residents to use that language, this is actually very powerful trauma-informed care. So when we begin to, if we're over here relaxed, comfortable, energized, and if something's happening in our environment, we might experience mild discomfort, agitated, or high discomfort. So for you, think about how that shows up. Perhaps there's certain residents or situations that when you're with these people or in these particular situations, you're noticing that your body is changing. Our bodies are remarkable by letting us know how the experience is showing up for us. So the more that we can be attuned to this, the more that we can have more success with grounding strategies and helping people come back on board with being regulated. I also want to share this with you. This is something I created recently based on, I'm constantly reading and studying this work. There's something called the anger continuum. Again, the work of Sarah Payton. And what I thought was, wouldn't it be cool? What if in nursing homes, we took this list? So you'll notice here, it starts with dissatisfaction all the way up to livid. So imagine that this is actually a long list, one list. I had to break it into two to fit it properly on a slide here. As we consider the words that we use as having less and less of a sense of mattering. So a lot of times when we feel angry about something, our sense of mattering, of being heard, of being understood, it's low. Okay, the angrier that we become, the less that we probably feel that we are being understood or heard, or that we matter. Okay, so if we were to have a list of these, and it would give another tool, I'm always thinking, what are tools that we can use to help people identify when they're feeling triggered and help identify when they're coming back to a calm state, a grounded state. So if we had this list here, we could share it with people. It could be laminated, it could be part of a care plan, and they could point, this is where I'm at. And then it gives us a way to talk about, okay, got it. you're really irate at this moment here. And then we can talk about that. We can figure out what happened in the environment. And then maybe hopefully we see them get back over here to just a sense of being dissatisfied with something. Or we can go back and we can use the body sensations. Okay, are we feeling more calm now? Is there a sense of release? So these are ways that we can bring this on board. Here's another idea. Some of you may be familiar with this. It's such a cool thing. It's a visual representation. So I would like to invite you, if we were in the room together, I'd ask you, please do this with me. So this is the hand model, the courtesy of Dr. Dan Siegel. He is a professor of psychiatry at UCLA. So basically what it is, it's like this. If I were to put my hand up like this, the prefrontal cortex is going to be represented by the front of my hand here. This is the spinal cord here, as you can see indicated in the picture. And the brainstem is going to be right here at the base of my wrist. When I am calm in connection, when I am grounded, my brain looks like this. My prefrontal cortex, the thinking part of the brain, is online. When I become triggered, agitated, emotionally stimulated, something happens in my environment, I literally flip my lid. So now you can see the amygdala part here. My amygdala did its job. It's scanning my environment 12 to 200 times per second. It identified a potential risk and it's going to flip my lid. What that means is my prefrontal cortex, where I have my thinking part of my brain, my ability to reason and rationalize and pros and cons and problem solve and strategize and be emotionally regulated, offline, it's offline. So this is something that's really cool. Also, they do this in some schools with kids, people. I also have some colleagues that teach nonviolent communication in the criminal justice system. And when people that are incarcerated have a different way to express their anger, it's so powerful. So I'm regulated and I'm dysregulated with my prefrontal cortex. Okay, love this idea here. When our brain is on fire from trauma, anxiety, or fear, it's very hard to remember resources. And that is why we are doing this work today. So by resources, it can be a number of different things. What we are going to focus on today are grounding strategies. So when our brain is on fire, we are stimulated, our prefrontal cortex is offline, we are trying to get back online when our amygdala is calm in connection. So why is it important for us to learn about supporting residents? It's because when another human being is dysregulated, when they are not grounded in connection, it can take the help of another person, you as staff, to help them come back online again. Now, I want to also point out that this is wonderful content we can use for our own selves as well. So when I identify I'm feeling triggered or agitated or in a state of distress, I have grounding strategies that I do personally to help my brain release the alarm, come back online, and become more settled. So these are things that you can do for your own self. These are things that you can do with your partners, your spouses, your kids. It can be done with anyone. Okay, let's talk about grounding. It is a method of distraction. So when a person is experiencing stress or distress, and the way that that's going to show up, folks, is distressing thoughts, memories, feelings, which I want to remind you include physical sensations, burning, constriction, that agitation, that being on fire kind of experience. So grounding is a method of distraction when all of that's happening on the inside to help us reconnect with the present moment. I'm very visual. As for those of you who have been in sessions with me, I'm a very visual teacher and learner for myself. This image to me is just so incredibly beautiful. Look at the sereneness, the connection with nature, the connection with water. If you look at the word grounding, it's connection with the earth. It's connection with nature. The other thing I want to point out here is that these strategies don't require therapy. That we're not doing therapy here. These are interventions or strategies, but I do believe it's important that we receive some coaching and some mentorship to implement these ideas. I really would feel a sense of distress if we just simply had to hand over these slides to staff and say, okay, go start grounding with people. So please understand it takes time and some practice and some familiarity to get comfortable using these techniques. So grounding helps us shift. I love this analogy too, from the then and there to the here and now. Remember, this is a beautiful way of conceptualizing. Remember, trauma is cumulative over our lifetime. So when we are triggered and emotionally stimulated, our amygdala says, alert, alert, put on the alarms. It's the then and there that are, because it's not timestamps, the amygdala took us back to another point in time. So the grounding strategies help to get us from the then and there to the here and now. I want to point also that we are talking in general about trauma-informed care principles. So grounding practices uphold, these are the ones I've identified. Perhaps you see it differently. For me, trust, definitely safety, choice, voice, empowerment, and collaboration. So I'm going to give you tons of ideas of different grounding strategies. The idea here is that you work with them, you play with them, you try them out your own self, try them out with one another, and then collaborate with the resident and or the family, the person that's involved with them. Teach them. This is where I think, oh, wouldn't it be wonderful if we could teach our residents and patients and families about what happens with trauma and an activated nervous system. Talk with them about all these different strategies. So be thinking as we go through this next sequence of slides, how can we take this content and put it in some kind of I envision a binder of sorts, or some kind of a policy manual, or something that we can use as a tool when we're working with people and say, hey, which one of these do you think might work for you? Which ones are you curious about trying? Breathing, there's a reason that I put breathing at the very top of this list. Remember that when a human being is activated, there's an alarm that's been sounded, our breathing changes, and we either go rapid, we slow it down. Sometimes I've even personally caught myself holding my breath, which is really not very pleasant. So I get stimulated or activated, something is happening that I find stressful. I find that myself holding my breath. So when I catch that, okay, I can release it, and I begin grounding practices around breath work. So the breathing that I'm talking about here is that very deep breathing. I know you can't see my abdomen on the screen, but we're really talking about, if you take your hands, put them on your belly for a moment in your abdomen. We're really talking about those abdominal muscles rather than those short upper body breaths. We're talking about that really deep, the belly breathing here. Exhaling, this was so cool when I learned this, and it made so much sense to me. I want to see if it lands for you all. Exhaling comes first because the CO2 that's in our lungs, we want to exhale it, get it out, and make room for that fresh, beautiful oxygen to come in. So you exhale through the nose, you inhale through the mouth. So we tend to say, take a deep breath when someone's agitated. It's actually exhale first. So just play with this, see if that works for you. It made a lot of sense to me. Here's one breathing technique. And again, there are so many, but I'm going to just pick up on a couple here. So the box breathing method, it's really quite simple. By the way, this is interesting. The Navy SEALs do this one. So I was like, okay, that's kind of cool. That breath work is not just something that we do in healthcare, or it's not just a part of mindfulness, that there's actually a ton of evidence-based research around this. So you're going to start exhale for 4. You're going to exhale for 4, hold the breath for 4 seconds. You're going to inhale, remember, inhale through the mouth, and then you're going to hold for another 4 seconds. The idea here is that you would be doing multiple rounds with this, multiple rounds of 4, 4, 4, and 4. So this is a very good technique. Again, there are tons. I did a little research. I thought, okay, I just want to give you guys a lot of ideas. There's several handouts on breathing techniques. So I invite you to play with this. See what you all think. University of California, Berkeley, breathing techniques for anxiety and stress, and Harvard. Isn't that cool? Harvard Business. So there's a lot of material out there. What I'm going to ask you to do is consider playing with this. Start off your next general staff meeting, start off your next stand-up meeting, your IDT, whatever your meeting structures and flow are. Try doing some breath work and grounding to start off the meeting. It doesn't have to take a lot of time. 2 minutes. Okay. I always smile at this. So, of course, babies are adorable. Usually they are. And I'm a huge dog lover. So I love to bring this kind of stuff into my work. I would love to see you all right now if anyone is yawning, and I'm having to stifle a yawn while I look at this slide. We don't know why people yawn. I actually did some research. I really was curious, why do we yawn? I couldn't figure it out. There was some speculation that we yawn to get more oxygen into the blood. Okay, that kind of makes sense to me, but it's unclear. But what we do know is that when I can stimulate myself to yawn, I purposefully do this. So I'll share a little bit of insight. Before I get ready to present or teach, I'm doing this one. I am opening my jaw really very wide, and I'm trying to stimulate my body to yawn because it's bringing more air into my system. I feel more grounded and ready to present. So inviting breath, this is, you can see or hear, I can just hear someone yawn and it stimulates that for me. It's a very grounding, soothing thing to do. Movement, super duper huge. When we get activated, now, if a person is so activated where they are physically out of control, this is not the time to bring in this sort of grounding strategy. What I'm talking about here, sometimes we get, I know I sit at my computer doing a lot of work and I forget to move. So helping reground is movement, wiggling your bum, move around cheek to cheek, feeling the chair, literally feeling what does the chair beneath your butt feel like? Moving your feet, tapping your feet, wiggling. This is all a way, it's not just doing the physical movement, it's really tuning in to the sensation of your body, that it's connected to the world, okay? That you're actually connected to the ground beneath you. More ideas about movement. So right now I'm going to ask you, I can't see you doing it, of course, but wiggle your toes, just wiggle your toes, curl them up really, really, really tight, wiggle them up and then stretch them out if you can in your shoes. If you can, kick your shoes off if you're at a place you can do that. Notice the sensation. So it's not just wiggling the toes, noticing what it's like to curl them up, squeeze them, and then the release. What does it feel like when you release your toes? Rubbing your hands briskly together, your palms. Notice, and I'm hearing the noise here, noticing that friction, that noise, and the warmth. This here is wonderful grounding because it's literally taking me out of my brain, the distressing thoughts and feelings and sensations, and I'm bringing it to the physical moment with my hands. Stretching your hands up towards the sky for 5 seconds at a time. Again, noticing the sensation. What does it feel like when I stretch my upper body? What happens to my head, my neck? Can my eyes go up? When you're doing grounding with someone, you're literally helping to point these things out. Mrs. Smith, what does it feel like? Can you describe to me what it's like when you do this? So it's not just plopping these ideas in a care plan or, okay, let's go ahead and ground, rub your hands together. It's not like that. We want to really tune into what we're doing to get that person's nervous system to release the alarm. Here's another idea. So what do you see? As you look around your environment, you can do this a few different ways. Name everything that you see, every color you see. So in my office right now, I've got colors all over the place. So you can name all the colors. You can do it like this. You can say, Mrs. Smith, name everything that you see that's blue in the room. Name every object you see. You can ask them, okay, what about we name the largest object you can see in the room to the very smallest. But you can see how beautiful that as a distraction technique, because I'm taking the person out of the distressing material and I'm refocusing. On something else. Same thing here. What do you hear? It's amazing when you go quiet. Listen very carefully. What are you hearing? Right now in my office, I'm hearing some noise outside of the office. I have a fan above me. I can hear the whirring and the fan noise. When you can really pay attention to what is going on, again, it's going to help to ground. If possible, go outside. This is so important. The more that we, and this is well-known evidence-based research, the more that we can get people outside and in nature, and then doing those strategies of what do you see, what do you hear, and what can we touch? Touch the flowers, touch the dirt, touch the grass, touch the tree, touch the pole, everything possible, because I'm shifting, I'm distracting from the distressing material. This is a great time for me to tell you about this really cool study. So this was put out in JAMDA, the Journal of the American Medical Directors Association, lower incidence of in-hospital falls in patients hospitalized in window beds than non-window beds. Isn't that interesting? So this was over 2,700 patients, and they looked at all the falls. That this was acute care. So I'm super curious, if any of you happen to analyze your falls data, I would be so grateful to know what you find out. Do you find that we have fewer falls with people that are by the windows than by the doors? Isn't that interesting? So there's some hypotheses around this, that it could be daytime light exposure that might have an impact on the incidence of falls. I kind of wonder, is it just because I can see out? I gravitate towards windows. I want to be able to see outdoors. So just something so interesting. Think about, see what happens for you all. Holding an ice cube in your hand and letting it melt. Again, notice the sensations. What does that ice feel like? What does it look like as it drips through your fingers and runs down your arm? What noise does it make when it plops on the floor? This is the grounding part. So don't just plop a handful of ice cubes in someone's hand, but really take them through the experience. A few more, naming categories. Any categories: cars, colors, fruits and vegetables, animals, cars, TV shows, cereals, movies, whatever you want. But these are the sort of things. So talk with a person. If we know that Mrs. Smith gets agitated whenever, fill in the blank. What of these could she engage in? Would she be willing to do? Okay, categories can be absolutely anything, of course. Music's a big one. We work in nursing homes. We know the power of music. We've read about it. We know music in memory. Listening to our favorite music, right? So why do we do this? It gives us chills and goosebumps. Guess what happens? It's so super cool. The brain has neurotransmitters. And what happens when we listen to music and we hear a favorite song that just gets us going, we get a flush of dopamine. Oh yeah, the dopamine is flowing. It's a happiness-inducing chemical. So that's why music therapy is so incredibly powerful. It's why we play our favorite songs over and over, because the dopamine flushes that happen in our brain, that helps turn off the alarm that the amygdala has stimulated. That's why we listen to them over and over. Strong flavors and sensations in the mouth is another very powerful grounding strategy. Just a smidgen of caution here. Oh, years ago, I was consulting with a facility. I'm in Arizona, so in Phoenix area, and in the care plan, this was a gentleman with some serious mental illness, and he really enjoyed, I forget what he loved snacking on. They used that as a care plan strategy. And then of course we had another issue with weight gain. So what I'm talking about here, a peppermint candy, literally biting down, I can't do this one, lemons and limes, but when we do this and we create a powerful sensation in our mouth, it helps with the distraction. Same thing with smells. We're very sensory oriented beings. Peppermint, bathing salts, oils, all of these sorts of things. Now I would say candles, but obviously we can't do candles in the nursing home. So, anything like this, having a basil plant, mint, they have a fresh little plant at bedside. When you take and you crush the leaves and you smell them, citrus does it for me. In Arizona, we have a lot of citrus. It's just a very powerful, very soothing. Texture and touch. Again, very powerful. Some of you in your communities may have activity cards that are full of sensory stimulation. Maybe some of you even have snoozling rooms. This reminds me of, for those of us who have kids, they probably did some exercises like this where they have to go and get different textures and put them on a poster board. It's not just putting them on there and saying, oh, that's spongy, that's soft, that's bumpy, soft, and spiky. It's actually touching and feeling them and talking about them, actually taking in the experience. That's the part that we get to have grounding. So the little one here, the holding, and we do know the power of stuffed animals, not to infantilize people, but we do know that baby dolls and stuffed animals, there's all those realistic ones like the seals and all those things that we can use. I want to show you a grown-up version. This story I found a while back, and I love it. I just love it. This gentleman is 94 years old, and this is a few years old. This was in England. His wife had died. They'd been married 71 years. So what he'd been doing was going to sleep with a picture of her in a picture frame, going to bed with her in a picture frame. The CNA, what she did was, I imagine something, whatever, a photo like Shutterfly or something, put her picture on a pillow, and what he's doing, he's showing, he's like, look at my wife, isn't she beautiful? And now he can have the visceral, very tactile experience that's connecting him to someone he dearly loved. Even though she's dead, he can still be connected. This is very comforting. Laughter and tears. Again, I'm sharing a little personal stuff on this one. If any of you go and watch that video, Britain's Got Talent, Susan Boyle, when she was discovered in 2009, she walked out on the stage from a little town, I don't know where it was that she was from. She walked out on that stage and she sang, I Dreamed a Dream. I watch it now. I just tell you about it and my body is flushed with goosebumps. It was one of the most moving things I'd ever seen. So when I need that kind of pick me up and grounding experience, I go watch this. The other one that makes me laugh is okay, it's Cookie Monster. I said it. I'm on a webinar and I said, I like Cookie Monster. This particular, it's a Siri, and I'm not getting anything from Siri, trust me. But this one just cracks me up. The way that he takes the measuring spoons and he flips them around on his finger and they go flying off is just so funny. It touches my kind of funny. Whatever toots your horn, folks, laughter and tears are huge. This lady, this is a receptionist on one of the nursing homes here in Tucson during the pandemic. She brought laughter. There was always a smile. I can tell she's smiling even with the mask on. I can see it in her eyes. Laughter whenever you can. If it's something fun in your next resident meeting, staff meeting, whatever, watch this TED Talk by Sophie Scott. It's not that long. You'll see why this is so powerful from a neuroscience perspective. Snuggling animals. See, I'm giving you guys tons of ideas here. So how can we bring these to life? Pet therapy, again, not for everyone, but for some of us, pet therapy is very powerful. Thinking about someone who loves us. This person can be alive or someone who has died. How can we bring this alive? Whether it's the pillow, like the gentleman I just showed you, a picture in a room. It could be an audio. It can be a recording. There's so many ways to bring this part alive, because the really cool thing, guess what, you guys? The amygdala also stores memories of joy, of peace, of contentment, of safety and security. So I could be out shopping somewhere and see someone in side view, and it could remind me of someone from my past, perhaps a beloved teacher. I played softball, so maybe a coach. I have a few coaches that were very instrumental in my life, or perhaps someone that I really, really loved, and I can see a person and my body automatically calms. So our amygdala is very powerful. Another idea, rerunning sporting events. This could be a very fun strategy. Sporting events or movie scenes, whatever gets people away from the thoughts in the hamster wheel in their head. This could be powerful. Picturing a beautiful place in nature. This is actually a picture. I'm in Tucson. This is a sunrise in my Sonoran Desert. So putting these ideas and pictures and imagery around our residence rooms and bringing them to life. And then how do we help staff to engage in the grounding strategies? Another one, compassionate self-talk, creating mercy and gentleness. This is Imam Jamal Rahman. I went to a training with him years ago, and it just was so powerful. Placing your hand, literally putting your hand on your heart and talking to yourself. Paige, your soul is aching for peace and comfort. I hear you. Oh, I just say those words and it affects me. I hear you. Talking to ourselves, compassion and gentleness. So you could help a resident come up with their own self-talk. Some people enjoy mantras. I've listed a few here. I call upon the peace of my soul. May there be joy in this day. May I bring joy to others. That was one I was using for a while. A hard moment does not mean a hard rest of the day. I'm choosing grace. Or just a simple thank you. You can even put your hand on your heart as you do these. So what happens physically? When we experience grounding, the sense of being grounded, there is a relief, a release of the agitation and the emotions and the physical sensations that we're just like a ping pong machine. We're bonking around in our bodies and our minds. Some of the signs that you might see that you have helped a person to become grounded, they exhale. That's a big one. Back to that breath stuff. Their face will change. There's a softening. The shoulders will relax. They're going to drop. They're not going to be up here by my ears. There might be some tears. A big one for me, goosebumps, always goosebumps. A pause in the speaking. If they continue to speak, there's more relaxation and not that rapid, pressureful type of speech. You will know it when it happens. When you see it, it's absolutely beautiful. To me, it's kind of magical. There's an energetic shift when we have helped a person get grounded again. Okay, so I'll come back to these in a moment, but I want to talk about one specific one that I didn't mention in all of these slides, this sequence here. I want to talk about touch. Now, there's a little bit of caution with touching. So is it to touch or not to touch? There's no clear answer here. It really depends on several things. It's going to depend on the situation and the person. Some people are very open to being touched when they are in a state of stress or distress. Some people do not. So if we're talking about someone who is in a state of stress or distress because of something related to perhaps sexual assault, touching is probably not going to be the best thing at that moment. Some people just are not touching people in general. So this is a very individual thing. So I'm going to give you some slides and some content of how to go about navigating this potentially little bit of a challenging area. So what we know from the CDC is that sexual assault is sufficiently common that every long-term care facility is likely to have multiple female and male residents who have experienced rape, attempted rape, or contact sexual violence. So the learning point here is that no matter what we do when we go in, if it's to provide care to a resident in any way, shape, or form, if it's to introduce ourselves to them, everything from handshaking, some people, whether it's a hug or not to hug, we've got to be very attuned to the possibility that there could be some stress around touch in this person's lifetime. So what are the considerations? So it's not uncommon. I will identify myself. I tend to be more of a physical person. I really do enjoy giving hugs and receiving hugs for the most part, not every time. We want to normalize it, okay? There's nothing wrong with touching or not touching. I just want to implore upon you that it's an individual choice, choice is a very big trauma-informed care principle. So there's something very connecting when human beings can actually touch. It's very powerful and grounding for the resident as well as the staff member, okay? So touch can feel reassuring and nourishing, or it can feel invasive and threatening. It may communicate safety, trust, and care. It may trigger a reaction or some kind of a behavior. So we got to have cautions and demonstrate self-awareness and sensitivity to the complexities of touch. So that's really the learning point here. We want to make it very personal. And sometimes you can say, would you enjoy a hug at this moment? Would you enjoy me holding your hand at this moment? You can actually ask people. So be very mindful of the context of the touch. When people are in a care setting, there's typically a power differential between the resident and patient and the staff. Obviously, the staff typically will have more power in that situation, structural power. So a person might feel vulnerable. They may have just been in the hospital. They may have had all sorts of procedures and things done to their body, sometimes very painful things. Feelings of vulnerability, especially if they are wearing a hospital gown, feeling exposed or unprotected in any way. So their room, when we walk into their bedroom, it literally is like coming into their house. So we're letting them know that we're coming in. We're informing them of everything we do before we do it. So our visits are very much like in their very personal space, like when they're lying in a bedroom or in their bed, with the power differential. So be aware of that. For the resident in a coma, should we touch? Don't know. It's uncharted territory. The way that I would always approach this situation, I tended to want to at least make some physical contact while I'm also speaking to that person. So if you can ask the family, if there's someone that you can ask that knew them, was this person typically one to be receptive to hand holding, to touching, to hugging in any way? That's one of the things that we can do to give us some of those context or situational clues to know, should we or shouldn't we? And then just be attuned. Obviously, when someone is in a coma, it's very difficult because we are not going to get those clues. What you can do, however, is when you approach the person, let them know you're approaching, because we do know that there's the ability to hear, even though if they cannot express or let us know that they've heard, there's a lot of we believe that people can still hear when they're in a coma. So making sure that you're letting them know what you're doing, that you hope it's okay, and that you're very gentle, even transient, which means a short time, okay? A soft, gentle touch. Trauma-informed approach to touch. So here's a few things that I hope are providing some good training tools, training ideas for you. Do not assume every person wants physical contact. Read the situation, and if it appears touch is welcome, ask them. Is there a nonverbal? So if a person reaches out to give you a hug, and if you're comfortable, and I want to make clear, just because a resident reaches out to hug you as staff doesn't mean that you have to receive that. So making sure everyone's comfortable with it. If you reach out, if you reach out to your hand, does the individual respond? Do they reciprocate and reach towards you? Learning how to hug in a way that matches the resident. Like this here, I love this picture because what I'm noticing is there's a leveling, they're at the same level. There's what appears to be equal, like their arms are around in a way, it just seems very proportional, and like both are receiving it very well. So just make sure that we're aware. Okay, so let's bring this back around. I want to bring it back full circle and talk about person-centered trauma-informed care, and then also give you some care planning ideas. Okay, F675, person-centered care. I'm not going to read all this. You all know what this talks about, right? So trauma-informed care, person-centered, trauma-informed care, it focuses on the individual to have voice, to be empowered, to have choice, all of these things that we've been talking about throughout this 4-part series. All of these things here are really hand in hand with trauma-informed care. We identify what's important to people. We give them choice about their routines, what they like, what they don't, and that means grounding strategies. So the more that we learn about people, what really is important to them, that's the information that we can use to create grounding care plans. So when we have those care plans that talk about difficulty adjusting or adjustment difficulties, or I really dislike those behavioral care plans that are really selected from a drop-down menu and whatever EMR that we're using, I really would love to see it more personalized. So person-centered trauma-informed care, really asking yourself, is it regulatory compliance, or do we really uphold trust and safety and voice and choice? So I've given you some pointers to go through here. Does the care plan include known and potential triggers for reactions? What's meaningful to the individual? Which of those grounding strategies might they be inclined to be willing to try? And then ultimately, I would love to see us have connection care plans instead of behavior care plans. So I'm going to end it on just a couple more slides here. Trauma-informed care. This is my message again and again. It includes all of us as staff. Acknowledging that we have triggers too. There are going to be certain people, residents, patients, family members, situations that are going to stimulate our own amygdalas to go on alert, to say, I'm not doing this. There is something wrong with this situation. Staff, if I have supervisors and administrators on this call, please, please recognize that our staff are human beings just like our residents. And when their bodies are stimulated and they're in a reactionary mode, they need to have a place to go to get grounded as well. We can't expect staff, when they're emotionally triggered, to then go in and provide the best care to residents. It doesn't work that way. One of the ways that we can do that is this idea of impact sharing. I'm just going to give you one slide about this. Impact sharing is really listening to another person of how does that particular situation impact them? What happens to them physically, physical sensations? What are they feeling? What are they thinking? And what do they need? What do they need? That's really the work of nonviolent communication. So impact sharing is very much nonviolent communication. So impact sharing comes before anything like educating staff, training staff, telling them what they should have done differently, giving them advice, discussing the policy. When we learn about how staff are impacted, that's what we want first, okay? Impact sharing becomes before everything else. This will help our staff have a sense of feeling safe and that they matter, of being grounded in their environment where they work. So I'm going to invite all of you, what's one little thing that you might be taking with you today that got you thinking, ooh, I want to try that one out? If you would put that in the chat box, or we can open the mics in a moment. I just want to thank you for spending part of your day with me, and I'll turn it over back to Nikki.
Thank you so very much, Paige. As always, we totally appreciate you and all of the knowledge that you bring. Thank you to each of you for attending today's training.